Okay, so the remainder of this is some different techniques that the cochlea wanted us to review on auricular reconstruction. Most of these I would consider probably Mohs defects or, I don't know, maybe dog bites, things like that. The Anita Butch Contra Cutaneous Advancement Flap was first described in 1967 by these two folks and used for reconstruction of helical defects of 3 centimeters. 3 centimeters or less. In this method, the anterior skin and cartilage are incised at the base of the helical rim, forming these really great contracutaneous flaps. The posterior skin is not incised. This is where your blood supply stays. Rather, it's elevated from the perichondrium and serves as the vascular pedicle. The contracutaneous flaps can be raised unilaterally or bilaterally depending on the size and location of the defects. And once they're raised, these margins are reapproximated, and you can take care of standing cones and Burroughs triangles as needed. But this actually has really beautiful results. I've seen it a few times. Next is this tunnel procedure. I've seen this described in a few different ways, but what I believe they want us to review from this Converse 1958 paper is that you can lift up this flap of skin and then put some cartilage, mainly from costal cartilage, and then put the little flap of skin back down. Unless I'm not understanding this properly, I don't think it's a great repair technique because often you don't have this little flap of skin, right? You're missing this tissue and from a Mohs defect or a dog bite. But maybe when this was described, there's probably a lot more initial healing and then reconstruction afterwards. The other thing they want us to discuss is auricular hematomas. These are super common. You'll see lots of them in the emergency department from blunt trauma, wrestlers, boxers, sometimes randomly. And so the auricular hematoma can get infected, cause necrosis of the cartilage and contracture. The cauliflower ear is the most dreaded complication. This is a cauliflower ear. It's very unsightly. The way that you fix it is you lift up a skin flap and you debride all this neocartilage, and you can lay your skin flap back down. They usually turn out quite nicely. Of note, when you lay it back down, you need to bolster them just like after you would drain a hematoma. I'm hoping all you guys understand the management of a hematoma. If not, a small hematoma you can needle drain, plus or minus a bolster. And a large hematoma, you need to do an incision and drainage with a bolster. I would say always err on the side of a bolster and being aggressive with these, because I've definitely taken care of some that are 3rd and 4th recurrences, and 3rd and 4th recurrences after I was the 2nd and 3rd drainage. And so getting a tight bolster, even sometimes using a red rubber catheter that you suture in place to recreate this fossa here. Because reconstruction of this cauliflower ear never turns out perfect. So I think that covers what we were expected to learn for auricular reconstruction. Hopefully it was pretty useful. You guys should go over board vitals, and what I would do is in the search term put the word auricular. This should give you a dozen questions or so, most of them which are relevant. There's a few on facelifts, but I'm sure you guys are smart and you'll be able to get them, even though we didn't cover it in lecture.